Welcome to the Homegrown Heart Podcast, every Friday at 7 a.m. Mountain Standard Time with your host, Dr. Amanda Ryan, DO, MBA, interventional cardiologist, and a recognized expert in her field. This week's topics, board certified. To be or not to be? Help me welcome our host, Dr. Amanda Ryan.
Good morning. It's a beautiful mid-August day here in Carlsbad, New Mexico, and I'm Dr. Amanda Ryan, your friendly homegrown interventional cardiologist. Today is going to be an exciting episode, as always. Exciting and awesome are words I use a decent amount of the time because I have a lot of passion for what I've got going on, and it's really exciting to share it with you guys. Today we're going to talk about board certification, but we're going to take a roundabout way to get there with a lot of different topics thrown in. Knowing if your physician is board certified or not and the importance of that, I think is something that a lot of patients, and I'm going to really speak to lay people today on some of these topics, and some of these topics are really going to speak to other healthcare providers. So we'll have a good mix of interest, I think. Another thing from this week is a real theme after going to this conference in Boston, which shout out to Dr. Lauren Barron for really including me. Wow, talk about a conference. This was a very small, in comparison, 60 to 70 women in cardiovascular medicine. This was CT surgeons, vascular surgeons, interventional cardiologists, heart failure cardiologists, and cardiac anesthesia providers from all over the country. A great mix from large academics as well as from smaller places, a couple rural. And then there were several that were at large institutions, but not academic in cities or suburban areas. So the idea sharing was just amazing. And several things came through that really interested me from this. One thing was Stoicism. That's a philosophic view, and I read a little bit more about it. I had heard of it, but I didn't really know all of the core principles. So just saying, one thing for me that was kind of important was temperance. You know, it kind of said, we're going to leave this conference. Women get a lot accomplished in a short 2-day conference. Let me tell you, we were focused on it, a lot of different sessions. We covered everything from difficult cases in heart failure to complex interventions when we're putting stents in people's hearts and very complex. We had one of the Mass General Interventional Cardiology Fellows there. It's called the CHIP Fellow now. That's a complex, high-risk interventional procedures. So doing the riskiest of the risky patients, maybe someone that bypass wasn't a good option for, and so they're trying to fix them with stents. She gave some amazing case presentations, and just the complexity of cases they're doing is obviously what you would expect from a Harvard-type facility. So that was just great. But how that could relate to the rest of us in our rural areas, again, theme throughout the podcast, as I've stated, you know, we're about 1 to 10 suburban, urban specialists compared to rural. So as we try to figure out how to really cover things in the appropriate manner, you know, we need innovative ideas, and I definitely got some innovative ideas. But temperance on Stoicism, again, is somewhat of the, I'm going to go out here and I'm going to do 15 things different after coming to this conference, making connections with these women trailblazing in the world of cardiovascular medicine, and I'm going to do this, and this. It's kind of like your fitness goals. You know, it's the January 1st, I'm going to lose 50 pounds, go to the gym 6 days a week. But somewhere along the way, it's like December of the next year, and you're thinking, what exactly did I accomplish? So sometimes it's important to set goals. And I'm going to share with you guys some of my goals for this remainder of 2024. That way, sometimes verbalizing it makes me focus on it more. So one thing is going to be to move forward with our next accreditation for our surgical center, which is something we're actively working on. Another thing is to really commit to my fitness 5 days a week as much as possible, with continuing to balance my diet to the best of my ability. Another thing is going to be increasing my social media presence. And the primary reason, there was a lot of women there that do have a good social media presence. And, you know, what are your reasons for wanting to increase your social media presence? Again, I'm an interventional cardiologist. Everyone has different goals. I'm not trying to be an influencer. That's not, you know, my primary primary way of making money. That's not what I'm looking for. What I am looking for is a platform to spread awareness about cardiovascular disease, about the realities of rural cardiovascular care and healthcare in general, to contribute and connect with people that have ideas for how we can improve things, and to empower women in healthcare, women that have an interest in healthcare, trying to make sure that we are able to reach our goals to the best of our ability. In society, we've got to keep investing in our healthcare people, and it's a major goal of mine to invest in young women in healthcare. So those are some goals for the rest of 2024. I think that's realistic. Before I get back to the board certification, so again, there were so many amazing things with these women last weekend. That was one thing. The social media was one thing. The complex cases were one thing. And just the overall camaraderie. There was a speed dating event, and you went to every table and you talked 2 to 3 minutes with each of these women. That was great, because sometimes you go to something like this, you either gravitate towards the 1 or 2 other physicians that you already know, or you just kind of bond with somebody quickly, and then it's just you and them kind of spending some time together, idea sharing at the conference, which that's great. But the real point of this was to get exposure to a lot of different women. And so I'm going to have some of them on future podcasts. Again, some of the things they are doing, the ideas I got, I just can't really wait to share some of that with you. So that was exciting. And now this week, I'm off, quote unquote, studying for my board exam, interventional cardiology board exam. And, you might have noticed I'm in regular clothes and I have fancy earrings, which that's a little bit funny. Is it Givenchy or Givenchy? And I'm not sure. I call it Givenchy, and that's maybe because I'm a Midwest rural girl. One of my primarily Spanish-speaking staff members is like, I think it's Givenchy. I was like, okay, well, Givenchy earrings that I have. I do love fashion. And sometimes I'm so busy wearing scrubs and rushing from point A to point B that I don't really get a chance to focus on fashion anymore. So every now and then it's kind of fun to match your earrings with your outfit and just overall feel good about yourself. So, women, ladies, don't be afraid to express yourself. The girl who did give the talk, the physician on social media presence, she was very attractive, Arabic woman. She had jewelry matching to the nines, her outfit, and she said she dressed like that most days for work, which I can't imagine accomplishing that, but my hats were off to her. She's beautiful, she's lovely, she obviously cares about fashion, and I think she's likely a very quality physician as well, which I hate to say that you even have to say that. There is, again, this sometimes double standard that exists, that it's almost like you need to kind of look a certain part. And again, sometimes my tattoos, which again represent soccer, the medical field, my practice, my family, tributes to them, sometimes people don't agree with that. They think that gives a certain connotation to you or who you are. And while I respect people's opinion, other people's opinion of me is not really pertinent to me. So you gotta be yourself. So on the board certification route. So here I am trying to study for boards. By the way, taking a week, quote unquote, off to try to get that accomplished, but I was in the office trying to also catch up things. I'd been at a conference for a couple days, so I was trying to catch up a lot of work. And again, then there was a patient, kind of an angry, frustrated patient, demanding to see me yesterday. And my staff was like, well, she's not here. And they had called, needed an urgent visit, and a doctor in a bigger town, turns out their assistant had told them that they needed some medication changes, and so they needed to get in with me right away to make those changes. And I definitely understand that. And the patient was like, they called, my staff got them an appointment with one of my nurse practitioners, but once they got there, they were very adamant that they wanted to see Dr. Wright, and they were very upset, and that I was too busy, and that I was. And my staff came to me, and this is a patient who I have a long-term bond with, and it hurts. It does make you feel bad. It does make you, I do want to be there for every single patient. But again, at this point, we have a 10,000 patient panel. An average cardiologist has a 1,500 to 2,000 patient panel. So again, learning how to manage such a large patient panel in a rural area where, without much support and backup, it's a challenge. And I'm not going to say that I have all the answers, because I don't. I've said before, some of my specialist colleagues, again, they do make sure that you see them only. They have about 20 patient visits a day as opposed to the 30 to 35 range that we often have. And it takes 6 to 9 months to get into them. I just don't feel like, from a cardiovascular standpoint, if you're told you need a cardiologist, if you are my routine patient and you call for an appointment and it's 6 to 9 months, I don't know, whatever your cardiovascular problems are, probably, they'll either be better or you won't be with us anymore by 6 to 9 months. So that's just not realistic. So as I told patients, so I did go and see this patient, stop the board studying, stop the meetings, went and saw the patient, but I was very honest and very genuine. I'm trying to study for a board certification. And I understand that you've been told you need to see me as soon as possible. By the way, they had an appointment for the 21st, which is next week, by the way, but that wasn't sufficient. So you're here today, and my nurse practitioner was more than happy to see you, but I'm going to do my best to meet your needs. But do you want a doctor that's board certified? Does that matter to you also? And I don't know, do you care if your doctor's board certified, or should you care? Or as a layperson, do you have enough knowledge to really know if that's important? I was searching through some cardiologists yesterday. I know my board certifications are several. I was looking through a couple cardiologists' web pages yesterday, getting some ideas for this talk this morning. There's a cardiologist board certified internal medicine, cardiology, interventional cardiology, vascular medicine, endovascular medicine, echocardiography, nuclear medicine, and vascular interpretation. That's probably 1, 2, 3, 4, 5, 6. That's about 8 of probably about 25 to 30 board certifications that a cardiologist could achieve. And as part of that, every 10 years, in this day and age, most of these will be on a recurrent basis, every 10 years. I have 3 major board certifications, and I'm currently on, so about every 3 years, I'm taking a new board exam. To stop your practice and have focused time to study, to stop your family life in order to focus, and honestly, just to, at my age, not that I'm old, but to really have I need to sit down and study in a routine time and make a commitment to this. It's a challenge. I always thought, again, I'll never be one of those doctors that isn't keeping track of the latest, greatest in medicine. And you have to know what's going on, and you have to. Last night I was studying probably the area that I'm weakest on, and that is cardiovascular pharmacology. I know the guidelines, and I know which drugs that you're supposed to get in which instances, but I don't always remember exactly which receptor that they act on in your body, and exactly which, I'm going to share with Danny so he can share this slide that shows just the overall clotting cascade in humans and how truly complicated it is. It really gives, you're just like, wow, when you see how complex that clotting cascade really is. And when you consider it, how amazing it is that we're able to interfere with it in so many different places. But again, some can cause bleeding, some can increase our risk of blood clots. Some natural things occur in us at birth genetically that make us prone to clots or prone to bleeding. Then there are acquired things that can happen to us. COVID changed a lot of things in medicine, changed a lot of things in our lives. It increased the risk of blood clots dramatically. The vaccine, some of them also had some increased risk of blood clots in some people. And again, my point is not to be politically divisive in this podcast but some topics are going to be controversial. So I do know there's some people that felt like the vaccine was causing a lot of blood clots. It was. COVID was causing many more blood clots. Honestly, I'm a doctor that treats them. It was nothing during COVID to have people in the emergency room with blood clots in their legs and lungs that were just massive. New devices were developed to help suck these blood clots out. That's called CDT, or catheter-directed thrombolytics. On that note, I have to tell you guys, cardiologists are not the most creative bunch in the world, if you could imagine. But we have 2 acronyms for everything. So heart failure, when you have a preserved ejection fraction, so that means your heart does pump the normal 50 to 55, but you still go into fluid overload sometimes, versus heart failure that has a reduced ejection fraction. That means your heart doesn't pump very well. Typically that's the people with squeezes, a normal squeeze, again, 50, 55 or higher, reduced is kind of 40 or less. So that's HFrEF and HFprEF. So we're at the conference and we're using all these acronyms. I'm like, oh my gosh, sometimes cardiologists. And GMDT, that's guideline, or GDMT, that's guideline directed medical therapy. I imagine you're in front of a patient and you're like, we got to get this GDMT down. I'm like, these patients do not understand what we're talking about, but that's guideline directed medical therapy. Now again, learning to know the guidelines, because most patients you can fit into guidelines, and your test, your board exams, like the one I'm studying for, is definitely going to ask the guidelines, but you also have to be able to realize that each patient is different. There's a little room in medicine. It's an art, not complete science. Science is important. It definitely, you got to know the science, but you also have to know the art of it. If you have a patient who has a weak heart and their blood pressure runs kind of low, several of the medications that are indicated via guidelines to treat that patient's heart failure will also lower their blood pressure. Talk about pharmacology and confusion. The patient goes to the pharmacy, picks up 3 new drugs, and they all say they're for hypertension. What does the patient immediately say whose blood pressure is running 110 systolic and they're a little bit dizzy or lightheaded? They're like, I don't have high blood pressure. If anything, my blood pressure is on the low side. I spend a lot of time educating those patients that blood pressures whenever we have heart failure often need to be 80 or 90 systolic, which is normally a normal blood pressure, quote unquote, is anything less than 140, 145 over 85. The traditional 120 over 80 is quote unquote normal, but there's a range for everyone. But so you're pushing people's top number, that systolic blood pressure, to 80 or 90, as much as they're not dizzy and lightheaded. And the reason is because you're really offloading the work of the heart and giving it a chance to recover. So again, Esther Vorovich is a big heart failure doctor, Jane Wilcox, there at Northwestern, and they were just at the conference I was at, and they gave some amazing input and ideas, and they're genetic testing anyone that has a weak heart that isn't from blockages. And I was like, oh, amazing. We should all be doing that. But when I think about the resources that they have at their fingertips out of Northwestern, compared to the resources that we have out here, it's not the same. So trying to figure out how we can tap into those resources, how we can, again, Medicare's trying to give us some support, saying that we can educate community members to really be patient advocates, or to help us in get patients to the understanding level that they need. Because the truth is, with my 9,500, 10,000 patient panel, I don't have time. I'm saving lives. I'm doing procedures. I mean, in a rural area, everyone has to be functioning in healthcare at their highest capacity. My highest capacity is doing the complex procedures that I spent 15 years training to do and have now spent 20 years doing. Again, I have 25 to 30 years of experience at this point from the day I started doing these procedures to now. That has to be my primary focus. And trust me, I want to be seeing you for your office visit, and I want to have 30 minutes to spend with you to go over things. I want to talk about your HFrEF, and I want to make sure that you understand that these medicines might lower your blood pressure, but that you're not on them for high blood pressure. You're on them to help your... However, I'm one me, which again, I have an amazing team, but I am always looking for more amazing team members to really build and educate. Partners in Heart Health, our foundation, a big focus of that foundation. And if you wonder if you do support any of our events or any of our grants, what are we really trying to raise money for? We are trying to raise money so that we can increase awareness, as well as train more healthcare professionals and those people interested in healthcare from Eddy County in particular, but Eddy, Chavez Lee, the entire Southeast New Mexico region, so that we can really have a cardiovascular program that we're proud of, that continues to grow. So that's what we're really out there looking for. So again, studying pharmacology and ADP and thromboxane A2 and P2Y12 receptors and which ones are irreversible binders and which are reversible binders. That was what I was doing last night before I went for a 9 o'clock walk with my mom, because we had to get back on track, because there's just been a lot going on in the last 2 or 3 weeks, and we've fallen off our fitness journey a little bit. So, in addition to studying for boards and taking care of 10,000 patients and attending conferences and running several businesses, you got to make sure your fitness goals stay on the forefront too. SCAI is a large interventional cardiology corporation, one of our organizations. And they've kind of talked about, they have an opinion, they weigh in on different board certifications. One big question for cardiologists is it important for us to maintain our internal medicine? So again, I'm going to go through, which I've said in previous episodes as well, but I'm going to go through the kind of training process for how I got where I am. And there's a little bit different paths you can take, but some of the paths everyone has to be on. So to get into medical school in the United States, you need a 4-year degree. Then like me, I worked for a year on a master's as well, 4 years of medical school. Then at least 3 years of residency is absolutely required. You're considered an intern that first year, and 2 more years you're considered a resident. Okay, you can do pediatrics, internal medicine, family medicine, some specialties are that 3 years and then they're done. So those people might be 29 to 30 years old if they've went straight through all of those years with no breaks. If you want to do a surgical or medicine subspecialty, you either do medicine or surgery from the beginning after medical school. That's anywhere from 3 years. A chief resident year is 1 year. General surgery residencies are 5 years long. Then if you want to do any of the specialties from that, you're 2 to 5, maybe even 6 years post that training. So I was 3 years of cardiology post internal medicine training, then an additional 2 years of interventional training. And then if you want to train to do leg procedures or complex procedures, then you'll go on to even more training. Dr. Barron, the CT surgeon, she went to undergraduate, 4 years, medical school, 4 years, 5 years of a general surgery residency at WashU, 3 years of cardiothoracic surgery, and then 2 years spent abroad, I believe at Oxford. We'll let her tell when she's the guest exactly where she was, learning specifics of aortic complex surgeries in patients that have connective tissue diseases, which again is just, but wow, when you think about all of those years of training, what really goes into it, it's just crazy. So like in my instance, then the first board exam that I ever took was the internal medicine official physician board exam. Again, there are high stakes exams all the way along this. High stakes means it's a test. It's either multiple choice. There might be some essay questions, but it's pass or fail. Get a certain score or don't get into the training program you want. Don't get into medical school. Don't maintain your board certification. And again, relevance of this. Do you have to be board certified? What does it mean to be board certified? I can think of a couple very qualified physicians that I do work with on a regular basis that do not have board certification. Based on the training they did in Canada or England, they came here, they went through the process here, but based on the beginning of their training, it would never exactly be accepted in the United States for true board certification. Also, my mom's an experienced healthcare person, as you've gotten to know over the podcast so far. She was like, well, is it a money thing? I don't know. My review class was $2,000 and the board exam was $1,500. So $3,500 to stop in the middle of what you're doing and take a board exam. Particularly, again, I'm a DO. I did an MD, quote unquote, an allopathic versus an osteopathic residency. I took the internal medicine allopathic boards, probably still the hardest test I've ever taken of all of these tests. And then when I switched over, as I explained on the one podcast, to the DO training program, I had to go back, get my training approved by the American Osteopathic Association, and take that board exam too, which kind of delayed me of taking my cardiology, interventional cardiology on board exams, because I was now taking another internal medicine board exam, where they can ask me about infectious diseases and rheumatology. And I've always been the interventional cardiologist that did want to stay connected to general medicine. I've worked as a hospitalist a lot. I've covered ICUs. I've done different things. However, again, to go back and study the exact antibiotics that are common right now for your basic UTIs and sinusitis, in addition to knowing which size stent that you need and knowing how to put a stent in your leg and how to use intravascular ultrasound to make sure I'm getting the right size. I mean, there's only so much that any one brain can handle at any time. So again, this SCAI, as I was saying, kind of weighed in on this. Should you continue taking your internal medicine exam, in order to take your cardiology or interventional cardiology or vascular, any of these other subspecialty exams? And obviously that's kind of a hot topic right now. Actually, they have changed after I struggled to take my internal medicine renewal exam a few years ago. They then changed, and now it's called maintenance of certification, or MOC, where you have to do certain modules every year, as well as obtain a certain amount of continuing medical education, which was already a requirement. And then you take some online quizzes, tests to kind of maintain your certification. I understand the point of it. The point is to make sure that a physician that has graduated from residency, 20 and 30 years ago I'm not giving you the same medications that were 20 and 30 years old for the most part. Although I will be very fair, the latest, greatest is not always the best. I always tell people, I don't want to be an immediate early adopter. I don't want to be the last adopter of a change or a medication in healthcare. I kind of tend to stay with the guidelines. I watch when something new comes out. I watch a technique. I go learn about it after it's been out for a year or two. You don't want to be 10 years in and your patients still aren't getting the access to that kind of care. But the first people that do it often see a lot of the side effects, problems, issues, bad outcomes. That's all true too. I mean, we put drugs, the FDA in the United States puts drugs through a pretty extensive process, obviously. But there are times when we still find out post-market a lot of issues with those medications. The other thing is the cost. The latest, greatest drugs are wonderful, and they tend to cost big money. Plavix is a great example, or clopidogrel. I trained when it was the only drug that we had to give people after they had a stent. We're the makers of, and I don't even remember right now the makers of clopidogrel at the time, but Plavix cost $400 and $500, and I trained in St. Louis and Detroit. There were a lot of patients that could not afford $400 and $500 Plavix, that did not have insurance and could not get that drug. They also weren't jumping through the hoops of trying to make sure that they got patient assistance programs put in. Some of them didn't have any official income to record. There's just all kinds of social complexities to the situation as well. But needless to say, I spent a lot of time in the middle of the night in St. Louis and Detroit helping patients, trying to unblock stents and save lives, and people that could they simply have afforded and taken their Plavix, they would not have been in that life-threatening situation. I remember when Plavix became generic, it was a good 7 to 9 years into it, and boy was I excited. Guess what? There were latest and greatest drugs, Brilinta, which is ticagrelor, and Prasugrel, which is Effient. And they're 12 times stronger, and you got to change all your patients to Brilinta and Effient, you can't still be giving them Plavix. Guess what? I'm still giving most of the people Plavix, and the people that are taking Plavix with baby aspirin after their stents are still doing great. Acute stent thrombosis, which means acutely blocking up your stent, is very rare still, and Plavix is $9 to $25 versus those other drugs, maybe again $400 to $500 depending on your plan. I'm talking about seniors that are often making the decision, do they eat? Do they pay their rent, or do they buy their medications? Again, focus of this is board certification, but there's a whole lot to talk about in healthcare that sometimes takes you on different paths. So as I'm reading about all these drugs on the board questions, again, studying pharmacology, sometimes I'm just thinking about the prices and the reality of these medications for our patients. So board certification, I do feel like is important, by the way. I'm giving a lot of, different roundabout, I'll give you my opinion. Yes, you need to make the effort as a physician to keep up with knowledge, to get back to your core science studying, but again, At what level? Does the cardiologist, do they really need to know how to treat a UTI? Do they need to know the latest, greatest antibiotics? Do they need to know the best medications for HIV currently? I mean, I wish I could tell you that I could remember all of that, and I'm interested in medicine, all aspects of medicine. I'm a lifelong learner. I love learning. But I'm also trying to take care of two busy practices, again, AHVNM and Advanced ASC of Carlsbad, New Mexico, running those businesses, taking care of a 10,000 patient panel, educating my staff, many of them from scratch, and staying up with technology, science, changes in medicine, pharmacology, and go take some board exams. So with that being said, I do think board certification is important. I think that you can be a quality physician and not have a board certification. And there are complex reasons sometimes. It's not always that people, and sometimes I do know good physicians that just, my interventional attending from fellowship did not pass his interventional cardiology recertification exam at one point. And as I look at taking mine on Friday with that same fear, I mean, I remember thinking like, how does he, that's like, he's very smart and he's teaching me, like, how did he not pass his board recertification exam? Yeah, because he had a busy family and a busy practice and he was busy teaching the fellows and you just run out of hours in a day sometimes. So we literally the next year took a month off, studied, focused, and passed that board exam, but I lost out on training from him for that month. And his family lost out of a lot of time with him for that month. And his practice lost out on him seeing all of his patients for a month. I don't even think taking a month off out here with what I currently have going on, I guess anything is possible. Sometimes God will put you in a position where you have to do certain things based on your health or otherwise. But I don't even really want to conceptualize what would occur if I had to, quote unquote, take a month off. So I hope today was a good discussion. There's a lot of different topics that I rolled in there, and I'm really enjoying sharing so many different aspects of medicine and my life with you guys. We'll have some more exciting topics coming up in the next few weeks. Be sure to tune in to keep your knowledge up with rural cardiovascular medicine and women in cardiovascular care. See you next week.